Again, thanks for everyone for being here for the GI emergencies, or we rather call them urgencies. So I'll talk about a couple of cases where we consider them GI urgencies. One is a foreign body impaction, and another category is caustic ingestions. So you may see them when you're on the wards or rotating on the GI service. Again, this is a pretty fun lecture, and my fellows actually enjoy it because they have participated in many of these pictures or images as contributors. So the first image here is actually a banana impaction that we had to remove about 6 months ago when we were on call with my fellow. And you can just imagine the excitement that goes along with that. All right, so I'll begin with objectives for foreign body impaction. So usually when we think about foreign body impactions or food impactions, we think about the sort of like the who, when, where, what, which, and how. So that is basically the population, when to do an endoscopy, the anatomical locations, and high-risk objects, choosing accessories, and how to protect the airway in order to do that. So foreign bodies in the GI tract, it's about 1,500 people die annually. So it is a high-risk area, pediatric group, elderly adults, those who are edunculous, patients with eosinophilic esophagitis, alcoholics, prisoners, and psychiatric patients. Again, when I was a fellow, there was a frequent flyer from psych patients that would come in just for secondary gain. They would impact objects, razors, pencils, just to get themselves into the hospital. So if you think of who and why, so foreign objects, generally children between 6 months to 3 years, people we have compromised mentation, those, like I said, with psych disorders or other related reasons, secondary gain like we talked about, or dental prosthetics that may accidentally be ingested. And the category of food impaction is generally those who have either an underlying pathology like a structural problem or a functional problem, in which case things can get impacted. So you want to think about basically the young and the restless, the old and the toothless is a category where things can get stuck. So this is the questions that I usually ask the fellows, and basically majority of the foreign bodies are passed spontaneously, and infrequently they need endoscopy. So again, it is an area of potential morbidity and mortality and highly litigious area. So you always want to consider the possibility of more than one foreign body. So in children, generally it's coins, toys, crayons, ballpoint pens, batteries. In adults, you think of food impactions, meats and bones, especially around the holidays. So again, when we're on call, we always try to reinforce patients to, chew food carefully so we don't have to be the ones doing the impaction removal. Dentures or sharp objects for adults. So this is when I was in my fellowship training. This is a list of some of the things that we had taken a picture of that we had removed during our fellowship. And this is a real patient, a psychiatric patient who had ingested spoons and as a secondary gain to get into the hospital. So patient presentation, as you can imagine, symptoms, it can be from anywhere from dysphagia, neck tenderness, painful swallowing. If they have hypersalivation or they cannot tolerate secretions, you think of it completely causing obstruction. You can have regurgitation or abdominal pain. So again, it's very important to gather a good history, especially if you can get what objects were swallowed and when they were swallowed. Physical exam is also important, as you can imagine. If there is subcutaneous air, you think about a perforation. If they're not holding your secretions or drooling, you think about a complete obstruction. Or if they have peritoneal signs, there may be a GI perforation. So radiologic imaging can help you in terms of locating the objects, or if there's any signs of perforation, whether it's in the esophagus or the GI tract, or like the abdomen, it can help you in terms of how to intervene properly. So again, a question that comes up from the ER is, should we give contrast, like doing a barium swallow? And the answer is no contrast is needed because it doesn't give you any additional information. It can certainly increase your aspiration risk, and it can compromise endoscopy, especially if you want to go down right away and remove the object. You're going to have this thick barium stuck to the esophagus. Generally, chest X-ray or CT scan are helpful for a suspected perforation instead. Another question I have is, where are the sites of physiologic narrowing, in which case food or objects can get stuck? Again, this is the where component of the objectives. So in the esophagus, there are 4 areas where things can get stuck, including the cricopharyngeus, aortic arch, left mainstem bronchus, or the distal esophagus. Beyond that is the pylorus, and then after that is the IC valve. But in general, if an object is bigger than 2 centimeters or longer than 5 centimeters, they're going to have difficulty passing the pylorus, the bulb, and making it through this duodenal sweep. So again, if you can always imagine the object, you think maybe where they get stuck, is it going to be above the pylorus or further down? And again, this is just another illustration of the sites. Again, the hypopharynx, the upper esophageal sphincter, the aortic arch. There's also left mainstem bronchus and the GE junction here. Pylorus is another one. And then making it into the duodenum. There's the IC valve, and of course the rectum and the anus. So when is the timing of endoscopy? So esophageal foreign bodies should essentially be removed within 12 to 24 hours to prevent complications. Again, that is for, of course, airway compromise, potential for perforation, or if you're developing aortic or pulmonary fistula, if an object stays there, causes inflammation and further complications. Again, what are the indications for urgent endoscopy? So respiratory distress, if anyone has pain, they can't handle their secretions, especially button batteries, and we'll talk about that in a little bit. Again, sharp objects below the UES. If it's above the UES, that usually is an ENT consideration. I mean, sometimes GI does get called, but again, if you can locate it with imaging, you can figure out who exactly to call for that. Again, PA and lateral films are good to determine the location in the esophagus rather than the trachea. So let me see here. Okay, so basically this is a PA lateral. You can see on the left image, you really don't see much, but when you do the lateral film, you see this fishbone here that is actually impacted. So it's important to get both films to be able to locate the object. Again, this is more tailored for GI fellows and those who deal with the tools, but we have many tools to remove objects. So one thing I do tell our fellows is if you know what you're dealing with, you can sort of, even outside the patient, figure out the right tool to be able to remove the object. Whether it's a snare, whether it's a rat tooth forceps, a basket, and you can sort of determine that beforehand. This is a really cool tool that we use as well, that we fit on top of the endoscopy. It's called a hood protector. If you have a sharp object, you can go in with this with the endoscope, and then once you retrieve it, the hood comes out once it passes the GE junction. So the object will stay within this, and the sharp object does not scrape against the food pipe. Again, we also use an overtube. This is a little bit more rigid and harder to use, but it's essentially the same idea. You have to actually put the scope through this and then do the endoscopy and then remove the object through this so that it basically keeps the esophagus intact. So how do we do it? Basically, the goal is to basically be very gentle when there is a complete food obstruction. You never want to forcefully push something into the esophagus and cause a perforation. So a lot of repositioning. Sometimes we try to angle things at the level of the GE junction to see if we can pass it through. Especially, we have to be careful if there's a bone spicule, because if you force the meat or food impacted, you can certainly scrape that bone against the esophageal wall and cause a perforation. So very gently. So if you can't push it through, you try to take it out. Again, we talked about using an overtube, and sometimes we use these grasping forceps to gently remove it. And again, just as a note, forceful pushing can definitely lead to a perforation, which is what we don't want. Again, the other questions that come up in terms of impactions, glucagon is controversial. It does decrease the LES pressure. It has very little success rate. I personally have infrequently seen it been helpful, and I think this data is correct. Again, in patients who have eosinophilic esophagitis, you can bring them back for a follow-up endoscopy, especially if you want to repeat their biopsies. Calcium channel blockers, nitrates generally do not work if someone has an impaction. This is another one that we had removed years ago. It was a 7-centimeter steak. I think it was Thanksgiving weekend. And so you can imagine that thing was had to come out. There was nothing else that was going to keep that going downwards. What about sharp and pointed objects? So these are like toothpicks, nails, needles, razor blades, pens, safety pins, and dental appliances. So the point is that leading points puncture, trailing points do not. So if you're removing them, you always want to trail the sharp edge behind so you can bring it out without causing problems, especially since you're withdrawing it through the esophagus. Again, this is another patient who had a can opener ingested in the stomach. So again, the pointed end is downward. So when you're retrieving it, you want to hold on to the other distal end of it. So again, remove the sharp and pointed objects before they pass through the stomach is the goal. You can use the overtube like we talked about. Again, there is a potential of perforation if it does get near the IC valve. There is this mural withdrawal reflex. Essentially, your small intestine can turn the objects. But again, we prefer to have objects removed before they get to the small intestine, especially if they're sharp or pointed objects. If endoscopic retrieval is not successful, you can consider surgery if there is no bowel movement in 3 days. You can use daily x-rays, or if the object is advancing with the pointed end. Again, another library of objects have been swallowed. This was in my former fellowship that was years before me, and there was like a gallery of all like the buttons and pins, safety pins that were retrieved. This is a button battery. It's another one that we sometimes get called upon. So we asked, my fellows, what is a potential complication of a button battery? And I'll answer that in just a second. So again, button batteries are in hearing aids, calculators, computers, and cameras. If they're large, they can cause problems, and their concern is rapid injury via direct corrosion. They can cause voltage burns or pressure necrosis, and that's a really bad kind of damage with liquefactive necrosis. So it is an endoscopic emergency. There's a high risk of potential esophagotracheal or esophageal aortic fistula. So you want to remove them if you see them on X-ray. Even if they're small, we still take them out. You definitely want to protect the airway. You don't want the button battery falling into the lungs if you are trying to retrieve it. Best to not puncture them with a rat tooth forceps, which is here. You want to get them with a basket. And sometimes using that overtube device can help you to prevent losing the object into the trachea. Most pass into the stomach if they're small. Especially if they're in the stomach, you use a basket or the net. If they are unable to be reached within the endoscope, you can follow them with daily x-ray. Again, we don't recommend using any kind of emetic objects or laxatives. If the patient has abdominal pain or failure to evacuate within 72 hours, we generally recommend surgical intervention for the reasons that we mentioned earlier. So shifting categories a little bit, this is a picture I showed the fellows, asking them what do they think this is. And I'll go ahead and tell you, these are cocaine body packets. Infrequently, we do get calls for, from the ER about a patient being in the ER with what they found on X-ray. And, ask the fellows, what is the best management of cocaine packets? Do you want to endoscopic remove them, rectal exam, spontaneous passage, overtube, or surgery? And the answer is endoscopy is contraindicated, and I'll tell you why. So basically, the cocaine is transferred through a condom, which can contain up to 5 grams of cocaine. Again, ingestion of up to 3 grams or 1 to 3 grams is a lethal dose. So you definitely don't want to rupture the packets, and you definitely want to remove them surgically. So if any of the packets gets ruptured with like any of our devices, then the patient can die. Now back to overall airway protection for patients. Generally, if patients are not cooperative, they're children or they're mentally ill, we recommend just doing intubation, which is ideal. If the patients are cooperative, like adults, moderate sedation can be used. We generally here just always go ahead and use the ET tube and intubate everyone who has an impaction. But of course, you always want to consider like their scores, the comorbidities to figure out. So just we're usually more on the safe side and rather just go ahead and intubate most patients with impactions. So in summary of this portion of food impactions, even as GI, we have to know the sites of physiologic narrowings where food or objects can get stuck, recognizing the indications for urgent endoscopy, especially when we are called at different times, if a patient has a button battery, sharp object, or the patient is in distress and cannot tolerate secretions. We have to recognize contraindications for endoscopic retrieval. Again, cocaine packets or anything that there's a suggestion of perforation, we do not intervene endoscopically, in which case we recommend surgery. Again, knowing people having eosinophilic esophagitis, again, it's a common thing, so we have to be very careful, especially if you're trying to retrieve the object or passing it into the stomach. Okay, so this is the first section. I'm going to go ahead and now switch over to caustic ingestion, which is another area of a GI urgency emergency. Fairly common, larger amounts are ingested in children. Generally, it's accidental, or people who have suicidal attempts, have mental health issues, or they may be intoxicated. Again, agents are usually acidic or alkaline. Acidic objects are, swimming pool cleaners, battery acids. Alkaline objects are very commonly the ones that we see are household cleaners, drain cleaners, oven cleaners, and lye, which was formerly used more commonly, and we are now seeing the potential complications of people who have ingested lye. So let's talk about the different kinds of injuries. Alkaline injury is a little bit more severe. It causes liquefactive necrosis, similar to button batteries, because it extends to all layers. There's a strong risk of a perforation in general. And then alkaline injury basically causes ulcerations, and over time, because of the extensiveness of involvement of the tissue layers, can cause granulation or stricture formation. So the esophagus is mostly affected compared to other portions because it doesn't have as much acid to buffer the effect of the alkaline. So the damage is very severe, usually higher up. The degree of injury is dependent on the agent, the quantity, and the duration of the exposure generally. Acidic injury causes coagulative necrosis, so usually thrombosis of blood vessels, and it's essentially more superficial. Because of the bad taste, people usually consume it much less, and there's like pain when swallowing, and therefore, patients are less likely to have severe issues with acidic injuries in general. But just like food impactions, patients who present with caustic ingestions can have pain like drooling, chest tightness, stridor, or shortness of breath. They can have epigastric pain, chest pain, or other GI symptoms. If the epigastric pain is pretty severe, think of a perforation. If they're having chest pain or back pain, you think about more of esophageal perforation or myastinitis. And again, an important point that I tell the fellows, sometimes the early symptoms do not always predict the amount of caustic injury or the late complications, because generally these things cause remodeling of the GI tract over time, in which case you see the complications. And I'll show you some of the cases that we've had. So the initial diagnosis of the caustic ingestion, again, an abdominal X-ray or chest X-ray can help you determine if there is a perforation. For those who have something higher up and they're having neck symptoms, you can do a CT of the neck or chest. If there is a perforation, obviously that patient goes to emergent surgery. If there is no sign of a perforation or nothing on imaging, an endoscopy is recommended within 1 to 2 days. And that is basically to prognosticate the degree of injury. And it helps us guide therapy in terms of early discharge or ICU stay or continued stay. So we use a Zargar classification, and I'll show you some of the images. Basically, grade 1 to 4, meaning the least amount of damage to slightly more with ulceration, and then higher up to deep ulcers, and then to perforation. So again, this is the same classification. Again, you can see just some redness, some swelling. This is a little bit more with ulcers, deep linear ulcers, and then this is basically some thrombosis, significant discoloration, and here is basically the esophageal perforation, which is the highest grade. So the damage is based on the grading. So the level 1 and 2A are almost like first and second degree burns. They usually heal without problems. Patients usually go home Grade 2B and 3, usually there's a high risk of a stricture formation up to 100%. And grade 4, obviously the mortality is extremely high, up to 65%, because that's when you're getting a perforation. I asked the fellows, again, what is the recommended management for caustic ingestion? And the answer is not to induce vomiting, not to place an NG tube, not to do neutralizing agents or antibiotic, but it's actually to call poison control. So of course you want to resuscitate the patient, call poison control, and like we just touched upon, grade 1 or 2A, you can start oral intake within 2 days and discharge home. The higher levels, 2B or 3, you admit them to the ICU, IV fluids, and monitor them. If they have significant respiratory distress and there's no perforation, you can do a laryngoscopy. Of course, if there's necrosis of the laryngopharynx, sometimes they need a tracheotomy. Grade 4 or perforation, they go to surgery, they get esophagectomy or gastrectomy. Again, the timing of the operation is depending on the individuals involved and institution as well. But generally, that is the decision plan. Treatments, like I said, were not recommended. You don't want to induce vomiting. Obviously, you can make things worse. You don't want to place an NG tube because you can also go through this inflamed area. So you don't want to place an NG tube. You don't want to neutralize anything. And again, no need for antibiotics unless there is an evidence of an infection. So this is actually a patient of ours. He is a 28-year-old man. I still see him. He is a barista who was one day, apparently they were cleaning out the kegs, and there was what he thought was leftover like beer in a keg, and he swallowed it. It turned out to be a cleaning agent. So again, he was brought to the ER. He was admitted. He got a scope within the first 24 hours, and you can see this is a pretty higher level, almost like a level 3, 2B, 3. You can see these deep ulcerations. It's almost like thrombosis. You don't see the vascular pattern. Very dusky. Again, there's multiple ulcerations even in the stomach body. Pretty significant. So he was in the ICU. He was intubated, and then he slowly got discharged. Then he came to see me, and he just basically could not swallow. This was about 6 to 8 weeks later. He could not tolerate anything. He had lost about 40 pounds. He had an esophagram done, showed a completely narrowed lumen. So we suspected he was having a post-ingestion stricture. For those of you who may not be familiar, this is basically a very, very small lumen. These are all scar tissue in the esophagus. And so we did it under fluoroscopy, and we did a dilation, and you see all this tear here, and blood is after we actually open up some of the scar tissue, which is commonly what we do when we do the dilations. He did a couple of these, and he was getting tired, so he wanted us to consider a different approach. So I actually did another endoscopy, weeks later, and placed an esophageal stent. This is how narrow his lumen is, and this is the top of the stent and the bottom of the stent, and this is the placement of a stent. Then we had to take it out, and then most recently, actually this is a little old, I've taken him up to 13 millimeters in diameter, but this area completely closes off very frequently, and ideally he gets frequent dilations, but we've talked about other options for him, including self-dilations at home, and he is not interested in any kind of surgical intervention. So essentially, this is some of the long-term sequela of caustic ingestion, such as this patient. He also had, if you remember the first picture I showed you, there was all this duskiness in the stomach. These are all some of the scar tissue that still he has in his stomach. So wrapping this section up, the long-term complications of caustic ingestions can include esophageal strictures, like we saw, higher with grade of injury, generally presents as 2 months after the injury, which does require endoscopic dilation or stents, and may even require operative intervention. You can also get antral and pyloric strictures, and again, about the same time frame, even up to 1 year. You can do endoscopic dilation, and sometimes you have to even remove their antrum. Esophageal cancer, it can be of increased risk after 40 years of age. So we do recommend endoscopic surveillance every 1 to 3 years, beginning 20 years after the ingestion. I will have to say that this is not as emphasized because usually people don't remember, or they may not be followed as well to make sure they undergo endoscopic surveillance. But if you do pick up people who have had an ingestion years ago, we do recommend endoscopic surveillance. for esophageal cancer. So for this section of caustic ingestions, initial management is resuscitation and poison control. Again, endoscopic intervention is required as long as there is no evidence of a GI perforation. And remember, alkaline injury does cause more severe injury and worse long-term sequelae, such as esophageal cancer. And this is a bonus question that I give the fellows, asking them what this is. And essentially, this is a pyloric stricture after a caustic ingestion, and this is barium filling of the stomach.